Fauziya Baidu, unmute yourself. You can start.
Start Corona. Good evening, everyone. I, on behalf of NEBAOI, welcome you to this NEBAOI classroom. Topic of this today's discussion is vertigo, clinical assessment. Speaker Dr. Bibuhti Das. Clinical assessment of vertigo, it is a very vast subject, and I feel it will be injustice on the part of NEBAOI to ask him to finish it in 30 minutes time. So I hope Dr. Bibuhti will do justice in this subject and try to include the important clinical aspect of vertigo. And moderator of today's discussion is none other than our Dr. Surajit Burman, a known personality in the world of vertigo. He is one of the pioneer of vertigo specialists as far as Northeast is concerned. He has done MBBS in 1999 from Guwahati Medical College, MS ENT in 2006 from Assam Medical College, trained neurotology under Dr. Anirban Biswas in 2010, and recently he is a consultant and in charge of vertigo clinic in Nightingale Hospital. So I welcome you, Dr. Surajit Burman, and hand over the mic to you, and you do the next.
Thank you very much. A good evening to everyone present, or to all my seniors, teachers, my friends, and my colleagues. A special welcome to Dr. Nilutpal, who has been our junior and is now doing very good work in Kolkata. He is now with Dr. Anirban Biswas sir. So, Nilutpal, welcome here. So,
thank you, Surajit. Thank you for the invitation.
Regarding vertigo, I think what Baidu has just said, or Fauziya Baidu, that it is almost a impossible task to complete the whole subject in a single talk. Forget about it being 35-40 minutes. I think even 3-4 days is not enough. So I think what Dr. Bibuhti is doing is great work, and this very attempt of his must be appreciated. Now, to say a few words about Dr. Bibuhti Das. Bibuhti Das has done both his MBBS and MS from Assam Medical College, Dibrugarh, and is presently working as a registrar department of ENT in the Fakhruddin Ali Ahmed Medical College in Borpeta. So without taking much time, I hand over the mic to Dr. Bibuhti. Dr. Bibuhti, please.
A very good evening, my respected teachers, my seniors, my colleagues, and juniors. First of all, I want to extend my wishes on this special Durga Puja, and I also want to express my deep gratitude and acknowledgement to the NEBAOI academic panel for providing me this opportunity to speak from this esteemed platform on a very important topic, vertigo and clinical assessment. Vertigo is one of the most common interdisciplinary clinical presentation that we clinicians are most commonly encountered in day-to-day OPDs or emergencies in our clinical practice. So it may be present as a sole clinical manifestation or along with other symptoms in a multitude of pathophysiologies involving the vestibular system, cardiovascular system, CNS, or maybe functional. So the onus lies on physicians to correctly diagnose the cause in a stipulated amount of time so that the proper treatment can be done. As this manifestation is very annoying, if properly not treated, so patient may have will get hampered his daily activities, and ultimately he may have anxiety or depression, and his quality of life may be impaired. And in some cases, we may lose the patient if the patient suffers from any CNS symptom. So strictly restricting to the topic, the clinical assessment of vertigo as a whole, with very limited experience, I will try to give this presentation restricting to the history and clinical examination. And if any such mistake is being done, so kindly I hope all my seniors and teachers will pardon me. So I will start with this presentation, Vertigo, the clinical assessment. So I will start the quote of W.B. Matthews, who said, "There can be few physicians so dedicated to their art that they do not experience a slight decline in spirits when they learn that their patient's complaint is giddiness. This frequently means that after exhaustive inquiry, it will still not be entirely clear what it is the patient feels wrong and even less why he feels it." So these were the words said way back in 1963. But I think now these words doesn't hold true, because there is so much of detailed clinical and scientific research has been going on. And now we can know what is the exact diagnosis of the vertigo, and ultimately we can reach to the proper management. So we know the definition of vertigo, who says that it is the hallucination of the movement which may consist of the feeling of rotation, swaying, falling, or tilting of the world or of the patient's own body. So it is derived from the Latin word vertere, which means to turn, and igo means a condition. So it is described as a subjective sense of imbalance, disorder of sense of direction, and it disturbs partial perception of the body. So it is not a disease, or it is a symptom of multitude of disease. So you can consider this as a tip of an iceberg. So it accounts for about 1/4 of referrals to ENT and neurology clinics, and approximately 1/4 of the people experience dizziness at some point of the time in life. And in 80% of cases, this is severe enough to visit a physician. So when a patient with a complaint of vertigo or dizziness comes to us in an OPD or emergency, he or she may describe his or her feeling in different words, like feeling of tilting, dizziness, rocking, fainting, spinning, lightheadedness, off balance, whirling, wooziness, wobbly feeling, and heavy-headed. So it is very crucial on our part to determine whether it is a true vertigo or other subtypes of dizziness. So Dretschmann has described this feeling of dizziness into 4 categories. The vertigo already definition has been told. So it is the pre-syncope, disequilibrium, and lightheadedness. So pre-syncope, it is a sensation of impending loss of consciousness. It is, and more commonly indicates that cardiovascular system may be involved. In disequilibrium, there is imbalance and postural unsteadiness. And in lightheadedness, it is called dizziness, giddiness, wooziness, or no clear definition has been given. And very recently, one of our staff nurse of our institute was referred from the medicine OPD to our ENT as a case of vertigo. But after taking history, it was determined that the patient was having extreme generalized weakness, and while taking a staircase, he was having feeling of lightheadedness. So it is very important on our part to determine whether it is a true vertigo or it is a pre-syncope, disequilibrium, or lightheadedness. So before going into the clinical assessment, very briefly, I want to share this slide and discuss about the physiology of the equilibrium and balance. So basically 3 systems, that is the vision, proprioception, and vestibular system are involved, and there is a very integrated coordination between the 3 systems, which helps us in moving our body or head during different our day-to-day life activities. And these 3 systems are considered as the main entrances of the sense of direction. And during our daily activities, very coordination among these 3 systems are aided by a strong auditory system, somatosensation, intact cardiovascular system, as well as a good mental health. If any of the system is impaired, so there may be a disorder of equilibrium. So pathophysiologically, the Struman has described the vertigo as a distortion or disorder of the sense of direction and a disturbed perception of the spatial position of the body. And this distortion may be caused by dysfunction of the peripheral vestibular organs, abnormal central transmission of sensory input, and impaired cortical integration. So after that, I'll come to the topic of the assessment of a case of vertigo, and it can be done by taking a very detailed, comprehensive history, bedside clinical examination, and investigation. And I will be speaking only regarding the history and clinical examination. So history, unhurried, detailed, comprehensive, and a structured history is very important in diagnosis of vertigo. But unfortunately, we are working in a government medical college and we are getting lot many cases in the casualty. So it may not be possible on our part to take a very detailed history if the patient presents with an acute vertigo in the emergency. And even sometimes in our OPD also, we are not taking our history, and that is, I think it's our fault. So we have to create an atmosphere or accustom ourselves so that we can take a proper history and a definite diagnosis can be achieved within a limited or stimulated amount of time. So the aims of the clinical history is definitely to reach the diagnosis, to clearly delineate the type, whether it is a peripheral vertigo or a central vertigo, and to know the extent of disability caused by the disorder. So why is a good clinical history important? So in our OPD, most of the time the patient's complaints of dizziness is vague. So we have to determine whether it is a true vertigo or it is a other types of dizziness like syncope, disequilibrium, or lightheadedness. And it is a very important or crucial aspect in casualty because a patient with acute stroke syndrome or TIA or CVA, patient may present with vertigo, and if not properly diagnosed, we may sometimes lose the patient. So we have to know the red flag symptoms and like the persistent worsening vertigo or disequilibrium, new onset severe headache, especially early in the morning, acute onset associated neck pain, unilateral hearing loss, diplopia, dysarthria, ataxia, lipedema, or any history of diabetes mellitus, hypertension, or any history of MI. If any of the red flag symptoms are present, so it gives a clue that the patient might suffer from any vertebrobasilar TIA or posterior circulation, it may be impaired. So patient besides casualty, so most of the time patient presence in our chamber or OPD generally in the symptom-free interval. So sometimes it is seen that we are not the first treating doctor. The patient may have visited the general physician or any medicine specialist or even orthopedician or neurologist, and they come to us for a second or third or fourth consultation or whatever. And we have seen that there is a whole lot of investigations are available starting from RE blood, even ultrasound, CT, and MRI. Even after that, if patient is coming to us with all the investigation report, so it is on very duty or responsibility on our part to create the atmosphere so that the patient is at ease and is at comfort, and we can extract all the comprehensive details from the patient so that definite diagnosis can be reached. So in most of the institutes in which vertigo clinics, certain questionnaires are given where patients are asked to fill up the performa, and after that patients are discussed or history is taken. So all these things I have tried to make simplified form, and all the salient features of clinical history has been written here. Like this is the onset, whether it is a single episode or multiple episode, the type of dizziness, duration, persistent or recurrent vertigo, it is rotatory or not, aggravating or triggering factors, whether it is improving over time or deteriorating or has remained stable over the period of time, whether there is any associated symptoms like hearing is involved or spared, degree of disability like history of falls, very important is drug history, and other diseases like of the cardiovascular system, CNS, endocrine, etc. So type of dizziness, the rotatory dizziness is that when the patient feels as in a merry-go-round, like due to labyrinthine causes like vestibular neuritis. If there is a postural imbalance like moving in or having in a boat trip, it may be due to vestibulopathy. Lightheadedness may be due to phobic postural vertigo. Dizziness and lightheadedness may be due to orthostatic hypotension, cardiac arrhythmia, hypertension system, panic attack, hypoglycemia, or in drug integration. So duration. So causes of rotatory vertigo, and if it is short-lived or less than 1 minute, so causes may be BPPV, labyrinthine fistula, vertebrobasilar insufficiency, caloric effect, vestibular paroxysmia. If it is due to, if the vertigo runs for a few hours, it may be due to Meniere's disease, delayed endolymphatic hydrops, TIA, vestibular migraine. Or if it is up to weeks, it may be due to vestibular neuritis, trauma, labyrinthitis, vascular lesions of the labyrinth, and CP angle tumor. And Causes of unsteadiness. If it is short-lived or less than 1 minute, it may be due to rapid head movements, a visual disorder, proprioceptive inadequacies. And longer episodic unsteadiness may be due to drugs, motion sickness, perilimb fistula, active CSOM, hyperventilation, or psychogenic cause. And prolonged may be due to aging, some drugs like anticonvulsant drugs, ototoxic drug, and CNS lesions like multiple sclerosis, Parkinsonism, and vascular disorder. So what are the persistent vertigo and recurrent vertigo? So persistent vertigo occurs they are more severe while walking or standing, which may be viral valvulopathy, psychiatric causes, aging, illness causes, or induced. Or recurrent vertigo, it may be due to Meniere's disease, perilimb fistula. All the important, most commonly that we've come across has been shown on the basis of the duration. So if it occurs within a second or minute, maybe due to BPPV or vestibular paroxysmia. If vertigo lasts for a few minutes to hours, it may be due to vestibular migraine or Meniere's disease. And if it runs for days, it may be due to vestibular neuritis. And if it persists for months to years, it may be due to persistent postural perceptional or triple PD or dizziness, bilateral vestibulopathy, or any central or central causes. So degree of disability or history of fall. Patients with peripheral vertigo are usually able to stand and walk without support, while those with central vertigo need support to do so. So if the ipsy falls or falls toward the site of lesion may be due to BPPV, Wallenberg syndrome, or vestibular neuritis. And controversial fall may be due to vestibular epilepsy or autolytic Tullio's phenomena. So severity. Some signs are difficult walking, darkness. Are you afraid to look towards right or left in as if to cross the road? Does the dizziness increases in a crowded place, or there is any fear of height? So these are some of the aggravating factors. So if the vertigo is present at rest, so it may be due to acute vestibular neuritis, downbeat nystagmus syndrome, vestibular migraine, or in Meniere's disease. If it is seen or it is present during walking, it may be due to bilateral vestibulopathy. And while turning head to the side, it may be due to vestibular paroxysmia or bilateral vestibulopathy. And changing head position relative to gravity is due to the BPPV. And on coughing, pressing, or loud sounds may be due to perilimb fistula or superior semicircular canal dehiscence syndrome. And during social or environmental conditions, so it may be due to phobic postural vertigo. Or standing up may be due to BPPV, or alcohol and exercise can induce vertigo in case of episodic ataxia. Tend to improve over time due to compensatory mechanism, and in central lesion is and may progress to deteriorate over time depending on etiopathogenesis. And drug history is very important. So you have to take the history if they consume drugs, microcystic, antidepressants, antipsychotics, sedatives, muscle relaxants, anti-allergics, alcohol, or any labyrinthine sedatives. So other associated terms like vascular autonomic regulation systems like changes in salivation, gastricity, vomiting, coldness, sweating, pallor. And very important is the dysfunction. If there is a history of feeling of pressure or in the ear, any history of ear discharge, history of trauma in previous year surgery, all this have to be asked to the patient. And so other systems like any hypochondria, failure of your cardiovascular problems like vasovagal syncope, orthostatic hypotension, and embolar disease or cardiac dysarrhythmias, hematological disorders like hyperviscosity syndrome, anemias, and anxiety if are to be taken. So
কি হল বিভূতিৰ কানেকশনটো কি হৈ গল নেকি বাৰু?
বিভূতি
নেটৱৰ্ক প্ৰব্লেম হৈছে নেকি?
বাইদেউ নাই।
দেখিছো এতিয়া
তাৰ নেটৱৰ্ক প্ৰব্লেম হৈয়ে আছে।
Oh,
Okay, he is coming back. He's coming back. He's coming back.
আহিছে নেকি?
Yes.
Oh.
Bibuhti, you can
Okay,
do one
continue.
thing. Bibuhti, you can do one thing. You can stop your video and try to speak. Bibuhti, are you there? Please unmute yourself.
শুনিছে ma'am?
Oh.
Yes, you can stop your video, then you will get a better bandwidth.
What you do is, Bibuhti, you make your video stop on only your unmute you and go on speaking.
স্ক্ৰীনত এনে কৈ থাকা তুমি। না স্ক্ৰীন শ্বেয়াৰটো থাকিব
এটা
দিয়া।
কি ma'am share কৰো screen?
স্ক্ৰীন শ্বেয়াৰটো থাকিব দিয়া, তোমাৰ ভিডিঅ'টো তুমি অফ
তোমাৰ
কৰা।
ভিডিঅ'টো অফ কৰি থৈ দিয়া।
তোমাৰ ফেচটো তুমি অফ।
তোমাৰ মুখখন যে ওলাই আছে সেইটো বস্তু তুমি
এই
ভিডিঅ'টো যে অফ কৰি থব
জুমত যিটো ভিডিঅ' আহিছে সেইটো অফ কৰা। তলত স্পিকাৰ আৰু ভিডিঅ' লিখা আছে যে। Yes, fine.
হৈছিল ma'am?
Yes.
বঢ়িয়া।
Alright.
So after taking all the points of his history, so there's rules to no cause. So if it is a true rotatory vertigo and it is associated with hearing loss and tinnitus, so we can show that it is 100% peripheral. If there is a history of any fainting attacks, syncope, or any blurry vision, so we have suspicion that VS may be involved. If there is an inability to walk, incoherence and incoordination of movement, so CNS or cerebellum may be involved. And if the patient has clearly indicates that labyrinth or central nervous system is involved. So now coming to clinical examination. So it is why clinical examination is important. So it is the cornerstone in the diagnosis of vertigo, and it is also time saving for the clinician, because rather than waiting for all CT MRI report to come, we can have a very comprehensive idea whether which system is involved. And also there is a financial implication of the patient. So there's a standard neurological tests that are that should be done are ear examination or otoscopy, posture and gait test, coordination test, oculomotor examination, positional maneuvers, hinge plus cranial nerve examination. So examination of the ear, so these are the few important causes like bacterial infections, viral infections, or wax, trauma, cholecystoma surgery, all may lead to certain, they have certain clinical features, and ultimately they can have presentation as vertigo. So fistula test. So we know what the fistula test, when we have to apply intermittent pressure over the tragus, or even we can apply Seagal's speculum, and after applying the pressure, if there is a positive fistula test, and these are seen in oval or round endo fistula, post epidectomy perineum fistula, or in fistula in semicircular canal. So false positive fistula test is seen in congenital syphilis or in Meniere's disease. And false negative fistula test is seen when there is a cholesteroma covers the site of fistula and doesn't allow pressure change to be transmitted to the labyrinth. Then test for posture and gait. So, these are the tests: the Romberg test, Unterberger test, gait test, and cervical posture test. So Romberg test. So this is a test of vestibulospinal tract function, and this test is performed with patient standing erect with both the feet together. First, we ask the patient to keep his eyes open and then close, and always we should be standing behind him on guard him. So in case when interpretation is that a positive in case of uncompensated unilateral vestibular lesion, where there is a consistent tendency to fall towards the side of the lesion. So this is the sharpened Romberg test, where the patient remains standing position with both the feet in heel to toe position, with one foot directly in front of the other, and both arms should be kept open over his chest. Then see, interpretation is same, but here always we have to guard the patient so that the patient doesn't fall off. So So this is a test video showing Romberg test where the patient tends to fall on the ipsilateral side while even after close and open. And this is the sharpened Romberg where the patient is keeping his heel to toe position and with both the arms over his shoulder. So Fukuda test and Unterberger test, here we ask the patient to march in place about by taking 30 to 50 steps with eyes closed and then arms extended. It is called Fukuda test, where you can see the patient is taking steps with both the arms extended. And this is the Fukuda test where the patient is lining his fingers and pointing towards the examiner's finger. So interpretation is that in case of unilateral vestibular lesion, the arm tends to deviate or the patient may turn excessively towards the site of the lesion. So this is the video showing the Fukuda test, where the patient is taking steps. And after taking steps, his hands are getting turned away about to 30 degrees. So after that, we have to evaluate the gait and we ask the patient to walk in a straight line quickly between the 2 points, first with eyes open and then closed. And we have to observe any signs of ataxia, extrapyramidal signs, musculoskeletal dysfunction. In unilateral vestibular lesions, particularly in acute stage, patient tends to fall in the same direction as that of the lesion. So these are the tests of coordinations like finger to nose test and this diagokinesis, rebound phenomena, dysmetria, pass pointing, and wide base gait. All these tests are done to detect any cerebellar disorders. Then oculomotor test. The purpose of the examination are to search for the direct ocular signs indicative of peripheral vestibular disorder, and also to exclude CNS lesions by making sure that vestibular mediated eye movements are normal. So these are the 6 eye movements: gaze holding, vestibular ocular reflex, optokinetic, saccades, smooth pursuit, and vergence. So examination of nystagmus, as we all know, that is the involuntary, rhythmical, and oscillatory movement of the eyes. And inspection of the spontaneous nystagmus, it begins in primary straight ahead position of the eyes. So always we have to know determine the direction of the nystagmus, whether it is right beating or left beating towards the ground, is it geotropic or agiotropic, or it has any sawtooth appearance or any pendular nystagmus. So these are the different planes. It is the horizontal, rotatory or torsional, and vertical nystagmus. So vestibular nystagmus, we can see that there is a distorted appearance, and in first slow component is towards the side, ipsilateral side or involved side, and fast component moves away from the affected lesion. So the Alexander's classification of vestibular nystagmus, there are 3 degrees: first degree, second, and third. First degree occurs when gaze is in the direction of first component, and second degree occurs with gaze in the direction of first component as well as in midline, and in third degree occurs in all direction of gaze, including towards the slow phase. So these are some differentiating points between the peripheral and central lesion. Peripheral lesions are mixed horizontal, torsional, and it quick fast phase moves away from the lesion, and slow phase with constant velocity. And it increases on removal of fixation. There is adaptation, and it follows Alexander's law. While central lesion, this may be horizontal, pure torsional, pure vertical, and it is the direction changing, and there is a poor separation with fixation. And it may be dissociated between 2 eyes, and there is no adaptation. So vestibular ocular reflex. So this reflex helps us to see clearly when we walk, run, or turns our head. So it is done by 2 maneuvers: Dole's head maneuver and head impulse test. So Dole's head maneuver is directly done by direct observation of the eye, measurement of visual acuity, and ophthalmoscopy. So here I am showing you one video of Dole's head.
In a comatose patient, if the brainstem is intact and the head is turned to the left, the eyes move to the right. If the brainstem is intact and the head is turned to the right, the eyes move to the left. Let's review the VOR pathway to understand how this reflex operates in response to an abrupt head turn. If the head is turned to the left, the horizontal semicircular canals, which are fixed in the temporal bone, rotate in the same direction. Due to inertia, the endolymph, the fluid within the semicircular canals, lags in the opposite direction. This increases signaling from the ampulla of the left semicircular canal to the left vestibular nucleus and decreases signaling from the ampulla of the right semicircular canal to the right vestibular nucleus. Ultimately, via connections with the abducens and oculomotor nuclei, this results in contraction of the medial rectus on the left and the lateral rectus on the right, which turns the eyes to the right, that is, in the opposite direction of the head movement.
So it is the dorsal reflex we have shown in the video. Now coming to the positional maneuver. So positional maneuvers are a vital component of the examination in the balance disorder patient, particularly in cases of episodic vertigo or vertigo induced by head neck movement or positions. The Dix-Hallpike maneuver and horizontal or supine roll test. This Dix-Hallpike is done in the cases diagnosis of BPPV in posterior canal semicircular type. So this is the diagram of Dix-Hallpike test, and there is one video.
The Dix-Hallpike maneuver is performed whenever BPPV is suspected of causing a patient's dizziness. The head is turned 45 degrees and the body laid back such that the head is extended about 20-30 degrees. If BPPV is present, eye twitching called nystagmus will occur. Eye twitching that rotates is called torsional nystagmus. Side-to-side eye twitching is called horizontal nystagmus. Eye twitching that goes up and down is called vertical nystagmus. The Dix-Hallpike maneuver is then repeated on the opposite side. This maneuver should be repeated several times to document for fatigability. When performing this maneuver, another individual can help. Please note that feeling dizzy but without nystagmus is not considered diagnostic for BPPV. Eye twitching must be present for BPPV to be diagnosed. Rotatory nystagmus indicates posterior canal BPPV for which the Epley maneuver is performed. Lateral nystagmus indicates lateral canal BPPV for which the Lempert's maneuver is performed. Vertical nystagmus indicates superior canal BPPV for which the deep head hanging maneuver can be performed.
So after that, this is the video of supine roll test.
The supine roll test assesses the horizontal semicircular canal for the presence of displaced otoconia that is causing vertigo. To begin, the patient lies in supine with her head midline and pitched up 30 degrees. Maintaining head position, the patient's head is turned to either side. In this position, the examiner will be looking for horizontal nystagmus. This is also performed on the opposite side. Depending on the direction and duration of the beating, various conclusions can be arrived at. Beating towards the ground is known as geotropic nystagmus and may be indicative of canalithiasis of the horizontal canal. Whereas beating away from the ground is known as apogeotropic nystagmus and may be more indicative of pupillolithiasis.
So very briefly, these are the features of different type of posterior canal BPPV, horizontal and BPPV. Where diagnosis by posterior canal involved, it is Dix-Hallpike. In horizontal canal, it is supine roll test. In anterior, which is quite rare, but still it is done by Dix-Hallpike test. Now coming to a very important clinical test, which is called Hinds Plus, and Hinds Plus comprises of head impulse test, nystagmus, test for skew deviation, and recently this has been added for hearing during test or audiometry. So in the year 2009, Kata et al. And Newman included the application of clinical bedside tests and which later modified as Hinds Plus. So this test is done only used for subset of patients who present with persistent vertigo, very specific within 24 hours of onset, and it has been said that this test is more than 98% specific in comparison to that of MRI in diagnosing any CNS lesion. So when the patient is having nystagmus or when there is a complete normal neurological examination. So entire HINS test has been very beautifully described in this video.
The HINS exam helps to differentiate central and potentially life-threatening causes of vertigo from vestibular neuritis, which is benign. It's comprised of 3 tests. First, the head impulse test. Second, the test of skew. And third, the nystagmus assessment. HIT stands for head impulse test. This test uses the vestibulo-ocular reflex to predict whether the vertigo is peripheral or central in patients with ongoing constant vertigo and nystagmus. This reflex allows your eyes to stay focused on an object despite head movement. Go ahead, try this now. Shake your head quickly from left to right, up and down, and look at the center of the screen. Your eyes will be able to read the words without any trouble. As you can imagine, this reflex came in very handy for a caveman running away from a saber-toothed tiger. The caveman would surely not survive if he couldn't focus on the direction he was going while bouncing up and down running through the jungle. This test is only performed in a patient who has active and persistent vertigo and nystagmus. You're trying to see if the 8th cranial nerve, the vestibulocochlear nerve, has been affected by a virus. To perform this test, ask the patient to stare at your nose, hold their head in your hands, and move the head 30 degrees to the side, and rapidly bring it to the midline while staring at their eyes. This method is preferred because it will avoid potentially over-rotating the neck, causing spine or artery damage. If the vestibulo-ocular reflex is affected by a virus, the eyes will keep moving in the direction of movement and then quickly jerk back to looking at your eyes. This is called a corrective saccade and will only happen in one direction, so be sure to test both sides. If there's a normal vestibular-ocular reflex, then the 8th cranial nerve is not affected, and your exam is very concerning for a central cause of vertigo. However, if the reflex is not working and you observe a corrective saccade, then you are reassured that the cause of the vertigo is likely peripheral, but you still must continue with the 2 other components of the HINS exam to be 100% sure. Again, please note you should not apply this test to patients who have episodic vertigo or are no longer symptomatic or do not have nystagmus. Here's an example of a patient with vestibular neuritis and therefore the head impulse test showing a corrective saccade. Notice that when the patient's head is moved quickly towards the left side, you see a corrective saccade, but you don't see it in the other direction. Here's one more example of a patient with corrective saccade and therefore a peripheral cause of vertigo. A very important thing to remember is that the brain can learn to compensate for this corrective saccade, and so it's important to perform the test randomly to avoid a false negative result. Also, be very careful in elderly patients who may have severe neck arthritis because the rapid head movement could lead to vertebral or arterial injury. The second component of the HINS exam is evaluation for nystagmus. Ask your patient to look slightly to the left and then slightly to the right and look for direction-changing nystagmus. The key here is not to have your patient focus on your finger because that can suppress the nystagmus. When evaluating nystagmus, the fast component of the beating is what determines the direction. Look for bidirectional or vertical nystagmus. Presence of this type of nystagmus points to a central cause of vertigo, meaning stroke. Here's an example of a unidirectional nystagmus, which is reassuring. Notice that the fast phase of the beating is always towards the left, no matter which direction the patient has to look. This patient is a unidirectional nystagmus and was diagnosed with vestibular neuritis as the other components were reassured. This is a pathologic bidirectional nystagmus. When the patient is asked to look to her right, the fast phase is towards the right. And when the patient looks to the left, the fast phase is towards the left. Most patients with a central cause of their vertigo do not demonstrate this finding, but if it's seen, it's highly specific for a central cause and a stroke. The last component of the HINTS exam is the test of skew. Ask the patient to look at your nose and cover one eye, and then move your hand quickly to cover the other eye. Look to see if there's any vertical movement, or diagonal or slanted movement as the eye is uncovered. Do this for both eyes, looking at each eye. Abnormal vertical correction is about 98% specific for a central cause of vertigo. So abnormal vertical correction is bad. Here's a video of the test of skew being performed on a patient. The patient is asked to look at your nose, and when you uncover the right eye, notice that the eye skewed moves medially and diagonally upward to look at your nose. This patient has a cerebellar stroke. So, to review.
So, this. When head impulse test is positive or when corrective saccade is present, so it is peripheral vertigo, and if it is negative, that means central vertigo. And if nystagmus is unidirectional, it indicates it is peripheral, and bidirectional or vertical is called central vertigo. And if there is no vertical skew, then it indicates that it is a peripheral, and if when vertical skew is present, so it says it is a central vertigo. So after we do all the examination of all the cranial nerves, so we're all aware of it. And after that, very important is that we have to measure the orthostatic hypertension. So it is that first we will examine the, we will measure the blood in the supine position. And after that, we ask the patient to stand erect wait for 3 minutes, and then we will measure the blood pressure. So any decrease in systolic blood pressure of more than 20 milligram of mercury or in diastolic blood pressure of mercury indicates that the patient may have orthostatic hypotension. So this is the summary of all the clinical tests. So if it is a case of true vertigo and acutely present, we have to do head impulse test. And if it is positive, so we can have the idea that it may be due to peripheral lesion. If it is negative, then we may conclude that there may be some central lesion. So if there is a recurrent vertigo, we can go for Dix-Hallpike test. And if it is positive, then it is a posterior canal involvement. And if Dix-Hallpike test is negative, we have to go for supine test. And if it is positive, then it indicates that horizontal canal may be involved. And if supine test is negative, then maybe we have to look for other cause. Very briefly about a very analyzed bilateral caloric test, which I think is not done routinely, but that's just I have given 1 or 2 slides. So it is sensitive to unilateral lesion of the peripheral vertebral system because it allows to stimulate each ear separately, and it evaluates the integrity of lateral semicircular canal and their afferent path. So here patient lies supine with address degree of the horizontal. So the horizontal semicircular canal is more in a more vertical position, and more lateral position of the canal leaves it more accessible to external temperature changes. And then we irrigate the EAC by either by air or water at temperature of 30 degrees and 45 degrees Celsius for 40 seconds and look for the observation of the eyes. And we are all aware that application of cold causes the movement of fast component of eye towards the opposite, and warm causes the movement of fast component towards the same side of the lesion. So after this clinical test, which are quite indicative of knowing the diagnosis, there are certain laboratory tests which are also done. Just I am giving the names like electronystagmography, video nystagmography, craniocorpography, video, VHIT, subjective visual vertical test, stabilometry, etc. So these are also done in all 2 subsets of cases where the diagnosis is of suspicious, or we are having suspecting some central causes. So finally, I want to conclude that vertigo has said to be the greatest heart-sink symptoms in clinical practice, but nowadays with routine good clinical history, bedside clinical test, and battery of investigation, you can now very safely reach the diagnosis of the vertigo. So it arises from a slew of vastly different pathophysiologies and it acuity ranging from minimally consequential causes to catastrophic implications. So it may be due to a wax in the external auditory canal to a stroke. So we have to clearly determine the cause. And vestibular causes and BPPV are the most common causes, and central cause are associated with neurological symptoms, the red flag symptoms, which I have already said in the other first slide. And assessment is done by a detailed, comprehensive, unhurried, and structural neurological history, and a very good clinical examination, and also the hearing test is important. A battery of clinical tests has been detect brainstem and cerebral stroke with greater sensitivity than neuroimaging. But selected cases requires laboratory vascular and balance function tests, neuroradiographic evaluation, and other serological tests. And proper assessment of the cause is pertinent so that definite management can be planned. Finally, I want to thank Anjana Sama ma'am, Surajit Bhavan sir, the moderator, and my faculties of our department in Pharmacy Borpeta, Birazdas sir, Anita ma'am, and Arkinath sir for helping and guiding me in preparing the slides. Thank you.
Thank you, Dr. Bibuhti. I must say, there's a saying in Assamese, Hatimari Bhurukat Bhurua. I think attempting to talk about vertigo in a 30 minutes talk is something similar to that. But I must congratulate you because you have very successfully done that. You have touched upon and elaborated wherever necessary almost all the aspects that we want to know from when we want to talk about the clinical approach to a patient with vertigo. And I definitely need to congratulate Dr. Bibuhti for doing such a good work. Now we have, before going into different questions that are being put up, we need to first bring out a few more aspects. And so if I may be allowed, the first question that I would like to get from Dr. Bibuhti. This is not a question. I'll say this is an opinion because what I have learned in my last 15 years of working in vertigo is, in vertigo, in many situations, there are no definite yes and no answers, and there are opinions. And your opinion and my opinion may be totally opposite to each other, yet both of us may be exactly correct. So first thing I want to know from Dr. Bibuhti, according to you, of the three things, history taking, clinical examination, and investigations, which is the of paramount importance, which is the most important thing in taking care of a vertigo patients?
Sir, generally we are getting patients who are generally of low socioeconomic status. But clinical examination, if done properly, if proper method is done, it may definitely we can have that idea of the disease, at least whether it is peripheral or central. You can have idea of conclusion. And investigations are definitely helpful because nowadays from very medical legal aspect also, and sometimes we may lose some very important and life-threatening conditions like acoustic neuroma. In such cases, if history and clinical examination is indicative, we can go for investigation. But besides that, we think clinical bedside examination is quite helpful, I think, in determining whether it is peripheral or central.
Thank you. I think you have very well said that. Bibuhti, what I would request you to is just something technical. Please stop share your presentation so that we can have a... Okay. And then you can put on your video on. Yeah, thank you. I think very well said. In not only for low socioeconomic condition, in any condition, investigation as far as vertigo patient is concerned is not of the most important thing. The most important thing is the history taking and the clinical examinations, because as most of my teachers have said all around, we should be able to pinpoint the diagnosis in around 90% of the patients only with history taking and clinical examination. I think there is a famous quote from Alan J. Kerr, who was one of the main editors of Scott Brown, who said the three most important thing in vertigo analysis is history, history, and history. So I think there are a few more questions. Before that, I have some comments from Dr. S.B. Fukan sir. He said a very good and a very well covered presentation. Dr. Anjana Sharma ma'am has said very nicely covered. Dr. Anindita wants to know what is the difference between positional and positioning test. So, Dr. Bibuhti, would you like to answer that?
Positional test and positioning.
Yes. You have little difficulty. I think the best person to answer this will be Anjana ma'am. Anjana Vaidu.
Yes. Actually, position, I have gone through some books, actually, authors. So there should not be any differences between positional and positioning test, literally. So we do some positional maneuvers to stimulate particular canal. Suppose something is there, we are suspecting an outlet in the lateral semicircular canal, or for that we do supine roll test. That is a positioning test, positional maneuver we can call it, and to stimulate the posterior canal, posterior canal as well as anterior semicircular canal, we do this Hallpike test, and to stimulate anterior canal, we do head hanging test. These are positional maneuver. So we do some other tests also, head in different position. So these are and we ask the patient to keep the head in that particular position where he gets a nystagmus. Some other position also are there, isn't it? Surajit, what do you want to share?
What if you put it in a very basic thing? Any test where we are doing a test for a vertigo that is precipitated by putting, like the patient comes and says that I am putting my head in this position, and vertigo is precipitated. Okay, so vertigo precipitated by that positioning of that head by the patient is positional test, and a vertigo precipitated not by the patient but us shifting the patient to that particular position is positioning test. So positional is when the patient's position triggers it. Positioning is when the examiner takes the patient to that position. That's the very basic. There are a lot of other things, but that is the very basics of it. That is the basics of it. Anybody else would like to say something on this? Nilutpal is here. Nilutpal can give us. Nilutpal, are you here? Nilutpal has a big experience. After all, he is with God of vertigo. Every day in and day out, he gets to listen to Dr. Anirban Biswas sir. So when you are, he's like in the presence of the Almighty. So he can tell us something. So he is not here. Anandita, I hope you have got your answers. The next thing I want to is comment by the person who is actually the pioneer of vertigo as far as Northeast is concerned, Akhil Sharma sir. He has a very nice comment. He says that while taking history and examining the patient, we should have in mind to exclude the disorders by the process of excluding the disorders one by one. There are more than 140 causes of vertigo. So that's trying to reach a diagnosis by the process of exclusion in vertigo. Vertigo is very, history taking on examination in vertigo is very different from history taking and examination in many other diseases, because number one, we were supposed to ask leading questions. Number two, as the history progresses, we should go about excluding diseases, and the algorithm that was put up by Dr. Bibuhti very nicely puts that what will happen with this and what will happen that, and if we follow that algorithm, I think we do have a very nice line of thought in that. We have a comment from Dr. Priyam Sharma. In a limited OPT time, it's a question. In a limited OPT time, what clinical should be at least done to arrive at a diagnosis? Bibuhti, do you want to answer that?
As BPPV is one of the most common cause, we should at least do a Dix-Hallpike, and after that, Hins plus, I think it's quite will be helpful in differentiating between peripheral and central causes.
Okay, thank you. Anything else? Anybody else want to say anything? So when a patient comes to me, what I tend to do, and everybody has a different set of doing this. What I do is, first of all, whether it's someone who is coming with acute vertigo, that is a vertigo of very recent history, few hours to maybe day, or somebody who has a history of long-standing vertigo. It may be a recurrent episodes or acute on chronic kind of a situation. So if it's acute, then as Dr. Bibuhti has said, the first thing I want to do is a Hins plus, because in the first 24 hours, as Dr. Bibuhti has already mentioned, Hins plus is better in giving us diagnosis of a central origin vertigo, particularly strokes, is better than even neuroimaging, than an MRI in the first 24 hours. The sensitivity is so high. So in an acute case, the first thing I would like to do is do a Hins test. After that, maybe I will go for the other test. In a person who has a vertigo which is a little longer, there I would like to again go for the clinical examinations constituting of first the ENT examination, then CNS examination, CVS examination kind of thing, then the positioning test, where I usually do the supine roll test first, Dix-Hallpike, deep head hanging straight. So plus in the CNS, I'll be doing all other things, the Artnerbergers, the Rombergs and all those things, plus thing. So I think in clinical setup, these tests are must. And if you're going on doing it, it hardly takes 5 minutes to complete these tests. So I think Dr. Priyam, you got your answer. Dr. Gautam Khan was raising his hand. Sir, you want to say something, sir?
I just wanted to, on the first question by Anandita, I just Googled and saw that they have mentioned that positional nystagmus, which occurs persistent while retaining a new static head position. It is called positional. And positioning nystagmus, in which nystagmus is provoked by the act of moving the head from one position to the other, but which decays over time, as in BPPV. Okay. So this is what has been given in the internet.
Okay.
Yes, I also agree with that. Actually, what happens, Anirban has also mentioned in his book that in positioning nystagmus, you have to do, the Dix-Hallpike. What I have written in my comment is a little, it is other way. In positioning, you have to do the Dix-Hallpike test, pure Dix-Hallpike test. Whereas in positional nystagmus, in the 3 different positions, that means sitting, lying down and standing, looking to right, left and center. That means there are 9 tests involved total. In 3 positions, 3 tests, and it will be 9 tests, and that is what is positional. And positioning is our purely Dix-Hallpike.
Thank you, sir. So all the tests that we do for BPPV, Dix-Hallpike, supine roll, those will be positioning tests, positional tests, and the others where we provoke by putting the head in different position, those are that. So I thank you, sir. I think Sarma sir has put that only in his thing. We have a comment from Dr. Zaman sir. He says it's a very lucid presentation. Congratulations to you. Now, again, before going further, we have a lot of seniors with us who have been in this field for so long. So I would like a comment from Dr. S.B. Fukan sir.
Hello.
Yes, sir.
Actually, very nice presentation, Bibuhti. You have covered in a very good way. Difficult to cover actually, but you have added the investigation also. Actually, is a clinical assessment. Actually, investigation just you have mentioned. But one thing I have to ask, well, you have mentioned triple PV. Actually, triple PV is a very peculiar thing. When it was, what is the difference between PPV and triple PV? Your pubic postural vertigo, which was described long back 1986, and this is actually PPV was only I think 2014. 2014, no? Am I right? Yeah, it
15,
was
sir.
known by 2014 by some consensus of some neurologists.
Yes,
And
yes, sir.
what is the difference actually? Why
So
they put
in
in PPPV and that is was phobic postural vertigo?
triple PD, which has been described not as a psychiatric but disease in 2015, and here there is a provocation by any attack or episode of means any vertigo, maybe manias or vestibular neuritis. There is a once time there is a provocation. After that, patient always remain anxious, always remain have that anxiety that I may again fall back. So whenever there is a movement or trying to see through the scrolling of the mobile, like means movement of the objects in front of him, then the patient may have this feeling of vertigo, to and fro movement.
Yeah, that means you want to tell it is a functional type, not a pure psychological type. And okay, then one thing why I'm your in the book you have seen your this supine roll test. Why you have raised the head to 30 degree? Okay, Dixolpike you have down 30 degree. That's okay. In the supine roll test, we have raised the head 30 degree in your demonstration. But in the book it is not written the raising the head of 30 degree. In supine roll test for lateral canal BPV, why you have raised the head to 30 degree?
To make it horizon to
So
hello?
if I may answer, sir.
Yeah,
Yeah. Initially, it was said that because of the angulation of the horizontal canal, we need to raise the head a little bit so that it becomes exactly 90 degree to the line of gravity. That
like
was
your caloric.
that was the original line of thought. However, nowadays that is not followed. Nowadays we keep it at the same position, normal supine position. And another thing that has come up nowadays is regarding the different positioning test for BPPV. What is now said is that it is not important what test you are doing. What is important is what is the nystagmus. So
Yes.
even Dix-Hallpike can give you a diagnosis of lateral canal or superior canal BPPV, or even supine roll can sometimes give you a diagnosis of a posterior canal BPPV, because the BPPV is diagnosed by the type of nystagmus and not by the position that the test suffices. So for
Yes.
a posterior canal BPV, it will be torsional. For a horizontal canal, it will be lateral. Vertical up, downbeating vertical will again mean a central lesion. So these are, sir, vertigo as a subject is so much, it changes. What is true today is different tomorrow. So I think regarding your, sir, previous question regarding triple PD and all, there's nothing I want to add. But if you remember, sir, there is a very nice presentation on this by Dr. Zulfikar Hazarika, who had presented during the live med session.
Yes.
So
Yes.
so I think how the way Dr. Hazarika Zulfida had presented it had made it very clear why is it is a functional test and why it is not a functional disease and why it is not a psychogenic disease. So the triple PD that we have today and the phobic postural vertigo that was described in 1984, there is a little bit difference between the two. The phobic postural is more of a psychogenic background, whereas triple PD is nowadays considered to be a purely functional disease and not of psychological thing. So when I have functional, that means there is a pathophysiological backing to that disease. The anatomy and the physiology is working fine, but the connection between the two, so there is a problem in the functioning of it. So that is why this whole thing, which was brought up by the Barony Society, uh, for different points in vertigo was put up, and that is why triple PD came up, sir. The details of it is there in Julfida's presentation.
Yeah, we have gone through a nice. Very. Thank you very much.
Dr.
Actually.
Surajit,
Yes, sir.
It is a really beautiful presentation, Dr. Bibuhti.
Thank you, sir.
Reason being, why I'm telling, I have heard many cases, many presentations, and I myself has also presented many. But the question is that how concisely in a limited time you can present such a vast subject. There is no doubt that this is a beautiful presentation. There are things which have been missed, no doubt, which we can discuss now. Secondly, in Dix-Hallpike test, it is not only the head down position where you look for the nystagmus. When you bring the head up, then also you will have to look the nystagmus, and it is usually reversed. It is usually reversed. If the nystagmus is present, then the head should be, when the head is brought back to sitting position, the nystagmus is reversed. That is a point I wanted to make. Thank you.
Thank you, sir. Very well made point, sir. What we must also now realize that what we traditionally thought of BPPV to be a spectrum of 3 diseases involving the 3 canals, the posterior canal, the lateral canal, and the superior canal, is now considered to be a spectrum of around 10 diseases, where there is divided into canalolithiasis and cupulolithiasis. So there are 3 cupulolithiasis. Again, the canalolithiasis is now divided into long arm and short arm. So because of that, there is another 6 more divisions. So at total, we have around 10 to 12 different forms of BPPV. And looking at the nystagmus at different positions, so whether the nystagmus is in Dix-Hallpike, whether the nystagmus is while the head is down, whether the nystagmus is while the head is coming up, where the nystagmus is geotropic, apogeotropic in different positions. So be it Dix-Hallpike, be it supine roll. So all this actually points us to different forms of BPPV, whether it is canalolithiasis, cupulolithiasis, if it's canalolithiasis, it is long arm or short arm. And treatment for each of them is maneuvers, but maneuvers are different. For example, in simple posterior canal BPPV, if we have a cupulolithiasis, we prefer the Simmons maneuver. If it's canalolithiasis, we prefer the Epley's maneuver. Why? Because cupulolithiasis, we need a bit of pushing, a little jerky motion, and Simmons is a very jerky thing, whereas Epley is a very smooth thing. The same in lateral canal. In lateral canal, if it's a canalolithiasis, we prefer a barbecue roll, the Lampert's maneuver. Whereas if it is a cupulolithiasis, we prefer the Gufoni's maneuver, again for the same reason. So there are even the simple thing of BPPV that we knew for so long. We did a Dix-Hallpike and then converted it to Epley, has now changed so much.
But how will you detect? Is it a cupulolithiasis or canalolithiasis?
Sir, it all depends on the nystagmus.
Experience.
The first phase of the nystagmus, whether it is geotropic or apogeotropic.
Geotropic,
so,
yes, correct.
all those things. And sir, this is a huge chart, as already mentioned. Sir, only on BPPV we can talk for 3-4 days. Then again,
because
another thing.
The Satish Mehta, actually,
yes,
I have asked him a question. He's from Jammu, very nice. Actually,
he's
why?
A very beautiful, very practical
very
presentation.
nicely. He how much explanation? He rang me up also. Then how the sludge is collecting. See how BPPV there may be sludge or some small autoconia, calcium carbonate in the canal. And when there is a person is little stagnant type, lethargy, he or she is sleeping in a bed in one side more. Then this large and small particle conglomerate to form the sufficient autoconia to stimulate the canal or coming to the cupula of the ampulla to stimulate. Very nicely it is explained. Therefore, it is very controversial. You cannot tell which one.
Sir will know very well. Phukan sir is
myself
both,
I'm suffering.
because
Therefore,
Phukan sir has not only treated BPPV, but he has experienced BPPV also.
Therefore, I will only ask question on the why there is recurrence.
Yes,
actually,
sir.
he has explained a nice, given me a very nice explanation.
Yes, sir. Even there is a whole point of canal conversion is there, sir, where we do a Epley for a posterior canal, and that posterior canal cured, but then the patient has now gone to a lateral canal BPPV, where there is canal conversion. So why there is canal conversion? Then we sometimes see why there is BPPV is supposed to get better with a single at a single episodes of Epleys, but it is not getting better. We need to do 2-3 times. So there again, we have this concept of otolithic strings. Instead of single otolith, we have a string of otolith, and this was actually proved by a electron microscopy photograph where it was pointed out that instead of one otolith, there was a string of otolith, almost like a string of pearl kind of a thing, where otoliths were attached to each other by a small string. And when we do Epley, half of the string was out, the other half was still in, and that was still causing the problem. So that is why I had asked this question to Kirtane sir once. Sir, what do we do? And he said, you do a Dixolpi, convert it to Epley, and immediately do another Dixolpi. And if that patient is again positive, do another Epley. And he said that I have even done 3 Epleys at the same sitting to the patients, called him back another few days later and done. What I usually do is I do a Epley and ask the patient to come for after 2-3 days and do another one. And I have seen in a few patients, maybe around 15 to 20% of the patients, we do need to do a second or a third Epley done. Another thing is regarding vertigo. What we have always learned was BPPV is the #1 cause, and the #2 cause was others. But now many of us have found that vestibular migraine has become the #1 cause in many studies.
Yes,
that is another thing which we were not thinking about. Today we were, just before this discussion, we were talking about something called vestibular paroxysmia, which is, I think, something very new to most of us. I haven't seen any patient of paroxysmia. Anjana Baidu, I think you haven't seen any either.
Oh.
No, Fazia Baidu hasn't seen. So most of us have not seen. And the diagnostic criteria, as Srinivas had said yesterday, is treatment with carbamazepine. So if the patient gets better, that means he has vestibular paroxysmia. If he doesn't get better, he is not having it.
Actually, nothing not there. Vestibular paroxysmia, trigeminal neuralgia, something. It is a mismatching with the vascular with the noodle fibers.
Yes,
therefore, I think it is the carbamazepine is given mainly on trigeminal neuralgia. But now they have tried for the vestibular paroxysmia
also.
But it is established carbamazepine given in trigeminal neuralgia. And that all your Mira operation, everything done, like hemifacial spasm, in the facial nerve also, they give carbamazepine.
Yes, vestibular paroxysmia, actually, sir, I think you will not know him. Dr.
But they
Pradeep
mentioned long back in Thomas Brand keep book and Michael Stubb books about this mention vestibular paroxysmia.
The problem is how to diagnose it. There is no, it's very difficult to diagnose a vestibular paroxysmia unless you are looking for it. So that's the thing. So
and Priyam Sharma question answer, actually Priyam Sharma has asked the question very nicely, because in a sitting on as a ENT specialist in a OPD, if a vertigo case come, what first test you will do? You will take the history in a short time, okay? He is asking like that, I think. The first test.
Can I share something?
You can share.
Yes.
First test you will do.
First thing is that as soon as the patient comes, you should see that whether patient can stand on his feet or not. That is very important.
That is the first.
So, peripheral vertigo is not that damaging. But if you fail to diagnose a central cause, that is not actually accepted. So first of, when a vertigo patient comes, what are their basic aims? We have to find out whether it is a vestibular or non-vestibular origin, and if it is a vestibular, whether it is a peripheral or central, and then we'll try to find out the pathological side. So basic thing is the history, clinical examination, and investigation. So in the history, 3TA we follow. 3T means type of vertigo, then time course, then triggering factor, and A stands for accompanying symptoms. So these are very important in the history. So 5 bedside clinical examination, very important. One is that you have already mentioned head impulse test. That will give you about whether it is a peripheral or central. And nystagmus, very important, whether it is a central or peripheral nystagmus, that you have to rule out if it is present. And if you don't have a pharyngeal glass, you can ask the people, they will provide Michael glass, or you can use 20 diopter, you can make it yourself, 20 diopter glass, and you just find and differentiate between whether it is a central or peripheral. So, and We have to taste that also the function of otolith organ by bucket test. You will find in the YouTube how to make the bucket. We can find out how SBB test is done. You can make it yourself. And positional maneuver is a must to rule out otolith in different canals. And also we have to test the vestibular spinal tract also by different positioning tests. These are the basic, you just can't, these are the things you have to perform to come to at least the diagnosis of a case of vertigo.
No, Anjana, yeah, that is not the question I'm asking. You have told all the vertigo clinic. For you sitting in a OPD, what test you will first do to detect something serious? That is okay. Posterior canal fossa infarct. One thing you can separate a posterior canal infarct and the vestibular acute vertigo. If there is posterior canal
Hints
infarct,
plus.
he cannot
Hints.
stand. He cannot
Yes.
stand first. That is
Second
the
is the
first point.
hints plus. Second is the hints plus.
No, his
Hints
plus
plus.
is difficult, but with the patient, first, it is Srinivas is always telling, the patient cannot stand. He cannot
That
stand
is
by
the
himself.
first. That is, yes.
You have to come by wheelchair, by attendant. That is the first diagnosis that it is a central type. Then you can go for Hin's plus.
Yeah, Dr. Fukan, I think it is a very important question
Very
Dr.
important.
Priyam has asked, because listening to all the tests of vertigo,
Yes.
we automatically get confused. And as you have mentioned that in an acute case, it is not possible to do many tests.
Hin's plus is easy, not easy to test.
Exactly. So I shall go for the nystagmus test first.
Yes.
And nystagmus test, probably that also some patient will resist, but still we can just keep on pursuing to see the nystagmus, because that will give us plenty of informations, whether the lesion is peripheral, whether the lesion is central. Even if it is horizontal also, we should remember that it may still be central as in a cerebral lesion.
Yes.
The difference being, in a peripheral lesion, it is a fine nystagmus, rapid.
Fine.
Whereas in cerebral lesion, it will be a coarse nystagmus.
Course and direction changing and everything.
Yeah, coarse nystagmus may not be direction changing always. But
moreover, these cases comes to a casualty department, tertiary center.
Coarse and slow. Usually it is slowly coming and it is coarse. So usually the nystagmus will be to the opposite side in case of a peripheral lesion, which also is very difficult to determine at the preliminary stage whether it is which side is opposite. But whereas in cerebral nystagmus will be to the same side. Then second test I shall like to do, because this is what about the vestibulo-ocular pathway. And if possible, we would like to test for vestibulospinal also by doing at least the Romberg, making the patient standing and trying to see which side he is falling, or whether there is tendency to fall or he is actually falling. So these two tests, I think, are the most important and the first preliminary test all of us must do to come to a conclusion at least whether we are dealing with a peripheral or a central, so far as the tests are concerned, because already the history will give us many indications, will give us many things to determine whether it is peripheral or central. Then of course the other test will come, but it is, as you have said, that it is the heat test. Heat test, it is very difficult by the naked eye to determine. So that's why we take the help of investigation instruments and all that. But it is very difficult to determine whether the eye is having a saccade or not. So that also we should try to see. But first thing is definitely the spontaneous nystagmus. Even the positional nystagmus patient may not allow on the very first day. If possible, we will do, that will also give us information. But nystagmus is first thing, because that is the surest sign of vestibular pathology. Thank you.
Thank you, sir. Dr. Anandita has raised her hand. I think she wants to say something, please.
Yeah, good evening, everybody. So I was listening to this webinar by Dr. Avinash Bijlani, there he gave some very solid points to differentiate between peripheral and central vertigo. So what he said was, if the patient can walk to your OPD and come, you should observe the gait of the patient. If the patient can walk and come to your OPD on his or her own without or with a little bit of support, then we can be sure that this is peripheral vertigo. Because in central vertigo, the patient will not be able to walk. So now comes another question: when we go to the ward or the casualty to see a patient who is lying down on the bed, so how do we assess that? So for that, he told us that we should look for truncal ataxia. You should ask the patient to sit on the bed and cross his arms. If the patient can do it without any swaying movement or a little bit minimal swaying movement, then you can be sure that this is a case of peripheral vertigo. But if the patient falls or sways unequally on all sides, then this is a case of central vertigo. So that is what I wanted to add.
Thank you very much. Dr. Gautam Khan has raised his hand, so you would like to say something.
Thank you, Surajit. I think these discussions are very fruitful. But what I wanted to say is that we can divide the examination into two scenarios. One is when you are teaching students, then you need to go the whole run. I mean, you need to do all the tests because students need to learn. But when you are a clinician in a private or in your chamber, then of course you need to do things as has been mentioned by most of the speakers. You need to concise and try to attack, targeted sort of examinations. But one word of caution is that there are many situations, even nowadays people are saying in sudden sensorineural hearing loss, one should advise an MRI because that could be a presentation of an acoustic neuroma. So even though I think there is no loss of prestige even if you're not 100% confident to order for an imaging study, because if you miss something in today's day and it is detected somewhere else couple of days later, it is actually very bad, because I think most patients would love to go for an investigation, but if you are absolutely sure that this is a BPPV, if you are absolutely sure this is a vestibular neuritis, fine. But if you have any doubts in your mind, I think we should not shy away from doing investigations. My personal opinion. Thank you.
Yeah,
Thank you
Dr.
very much.
Dr. Gautam, you are right. OCNA has also mentioned giving importance to doing an MRI in cases of vertigo, because straightforward, in majority of the cases, it will exclude a central lesion. However, we know that from first, second or third day, only positive signs start coming in many of the lesions. But in of course, in certain lesions, it will come immediately. So OCNA has also mentioned that. Only problem is it is a very comparatively costly investigation. And many times come out to be unnecessary, because we know that in 70 to 80% of the cases are of peripheral origin, where MRI is of no need. Remaining 20% only, it is of use. But still, OCNA has also mentioned that MRI is an investigation to be done first to see that whether we are dealing with a central lesion or not. Thank you.
Yes, sir, because in the recent past, sudden sensorineural hearing loss with severe vertigo, actually people have started advocating the MRI, especially posterior fossa, to rule out a posterior inferior cerebellar artery bleed, because that can be in the early stages, it can be picked up before it's too late.
Actually, posterior inferior, I think ICA or PICA? I think ICA. It is because internal auditory artery comes from ICA. Not from PICA. And one small case, Surajit, to give opinion. One case from Pathshala came 1.5 months back.
Yes, sir.
And she is actually 56 years old with deafness, tinnitus, vertigo, but no blockness. I do a audiogram, because from my home it is Nauka's hearing aid very nearby. She came within 5-10 minutes. She came audiogram. That is okay, low frequency loss. I diagnosed. I think it is many years. Therefore, I gave him as usual Bhartin, only 48 OD, and tinnitus okay, but then other supportive diuretic. Diuretic, I Diamox difficult to get. I give a Dietor. It's a little hypertensive also. Ultimately, after 1.5 months, she came from Patsala, only 2 days back to me. She is relieved of vertigo, but still I have asked him to continue. Only problem is the tinnitus. Tinnitus is not relieved. Actually, therefore, I have asked her to go for a MRI of the CP angle. Only for because you cannot do because the sons are all very well-to-do family, seen by Newton also there in Patsara. Therefore, I have told her, no, you have to go for MRI. No case I'll do. I think they have done yesterday. Let's see. It's an interesting case, something case.
Yes, sir. Sir,
Include this.
anyhow, sir, what I tell my patients always is, patient with tinnitus, be it vertigo or any other case, I always try to tell them tinnitus will be the last thing to go. And it's very, yeah.
Actually, any drugs also does not work anything.
No, nothing.
Only I do this a headphone of Sans headphone and do any bhajan or something like I've asked him. Actually, it's something comes down, but his advice there's a Zen music. Therefore, I have asked Anjana to develop some series on Zen music. Do you know Zen music? JD and Zen.
Zen is basically a Buddhist philosophy kind of a thing. So yes.
Oh, it is advised to go for Zen music in tinnitus. I don't know actually what is Zen music, but some people, some patient I have given to ask you to download from something because these kids are good. They are getting relief. I think something not because they are not coming to me. I think it is relief by counseling. I don't know. But Vibhuti hints plus. Why plus is used? You have not said about plus. Mention audiogram, okay. Why plus is necessary in hints?
So it was for audiometric evaluation, sir.
If it's okay, you have to do, but in emergency audiometry difficult to do for because all these cases, acute vertigo, they comes to tertiary center in casualty department.
Sir,
Therefore, it is
when we say hints plus, the auditory test need not be a pure tone audiometry.
yeah.
Even a simple tuning fork test can also be that.
Oh,
So
that's
when we
correct. I
talk
don't
of
know.
hints plus, we talk of audiological evaluation, but it's not audiometry, sir. Even simple tuning fork test
Tuning fork test
is
also. That
enough,
I
sir.
don't know.
So basic concept is that if there is audiological deficiency also, it points to a peripheral cause. That is why. So hints plus is that if there is audiological problem, then it points towards a peripheral cause. Although it's not always true.
Surajit,
Sir.
Give some chance to Kripamoy and the other.
No,
We
sir.
have discussed a lot.
Sir,
I know.
sir, next I was actually trying to get in Jaman sir's comments. So I have a list here. Jaman sir, then Dr. Kripamoy. So I was thinking of, so Jaman sir, if you're listening, sir, I'd like to have your comments, sir.
Thank you, Surajit.
Thank you, sir.
I do have very less experience on vertigo. I always listen to the meetings and webinars and learn a lot. Today also I learned from Bibuhti a lot. It is a very nice presentation.
Thank you, sir.
Congratulations.
Thank you, sir.
There is a lot of things to learn, and this is vertigo is such a thing. Every time you listen to a meeting in a webinar or anything, something you learn. Something. Yesterday also there was a webinar on that one. Your treatment only, drugs. That also there is a very nice presentation was there. So thank you, Surajit, for asking.
Sir. Thank you, sir. Dr. Kripamoy Nath, sir, if you'll kindly come up and give your comments on today's presentation and any addition you would like to do on the vertigo treatment, sir.
Thank you very much. Congratulations, Bibuhti, for nice presentation. It was very wonderful and nicely concised. Whenever there is any vertigo talk, I used to join. And one thing I'd like to ask is that how to diagnose, like which canal to be tested first for positional vertigo? When a vertigo patient comes and you think that this is a BPPV, and to which side you will test first, right side, left side, how will you decide?
Bibuhti, you would like to answer that?
So by nystagmus, so can we have some idea by looking into the nystagmus?
I think the basic thing is you ask the patient. You ask the patient, do you get vertigo on a particular position? If the patient can say that, yes, when I move to the right, the vertigo is more, then you test that side. But if the patient cannot say, in many times I have seen the patients are
Patients
both
are
sides.
confused. Sometimes they are confused.
They are confused. Then there is no specific thing. You can go accordingly. Even while doing the test. Now, the most common BPPV is posterior canal. So technically, we are supposed to do the Dix-Hallpike first. But I always find doing the supine roll first because you just lay the patient and do the supine roll. It's a very easy test. And that why I do the supine roll first is also a psychological thing because the patient is very much afraid of sleeping and moving the head. Patient of BPPV. So I just ask them to lie on the bed and I ask them to just move your head to one side and to the other. I don't even touch the patient then. Only one, and we get the supine roll. And once the patient is a little relieved that, okay, I'm not having anything serious, then I can ask the patient, okay, now I will try and move your head here and there and do. So until unless the patient, in many BPV, the patient will tell us that when I move my head to the right or the left, in those cases, I will always do the side where the patient complains. But if the patient is confused and do not do, then it's every clinician has their own favorite side. So,
Dr. Surajit,
yes, yes.
Is there any necessity to do both the test, Dix-Hallpike and supine roll? I think Dix-Hallpike, if you do, that itself will tell you that whether you are dealing with a posterior semicircular canal or a lateral semicircular canal, or even an anterior semicircular canal.
Yes, sir. Because as already mentioned, in Dix-Hallpike, depending on the type of nystagmus we get, we can very well say which canal is involved. The only reason I do supine roll first is to give a psychological trust to the patient because the patient is so afraid of even sleeping in the bed.
That will be part of
I have had, yes, I think Fukan sir will remember there was this patient who Fukan sir had seen initially, and sir tried asking the patient to sleep on the bed and he ran off. And then he said, you go to Surajit after 3 days. So that patient came to me after 3 days. By that time, his anxiety level, I think it was a she, her anxiety level had gone down a bit. So I could do the Dix-Hallpike. It was a simple posterior canal and we had done the apply. So that psychological fear, in one of the presentation, one of the foreign speaker had mentioned of a lady who for the last 20 odd years has not slept in a bed. She just sits on a couch because she's afraid to sleep on a bed. So is that BPPV? Definitely not. Her initial attack was BPPV. Now it has become psychological because BPPV is not going to stay for 27 years. So that's the thing. I think Anjana ma'am, Anjana Baidu wanted to say something. Anjana Baidu.
Yes, actually, why testing the different canals? Actually, we are supposed to test each and every canal because bilateral presentation and multiple canal presentation is not that rare. So what I do actually, as Surajit said, I do supine roll test first. So this is the actually it's comfortable for the patient also unless and until he or she is having a lateral canal BPPV. Then after that normally I do the which canal I think it's not affected, that canal I do first. Then I go for the other canal which is affected. If it is a posterior canal, at the same time I do applies. Then after that I'm there to do that Dix-Hallpike again, whether it is corrected or not. So that's what actually I follow.
Thank you.
In COVID days, actually, 3 days back, one of my sister rang me up from Ujan Bazar. Yes, she is having vertigo. Then I asked in the telephone, like Surajit says, lateral roll. They told me that it is on turning the head. Then after turning, when I contact her, she said, no, not the turning, by coming out from the bed. Then I thought it's a posterior canal or something like that. Then I, on the telephone, I give the WhatsApp, giving the, then you test whether left side or right side. Ultimately, she detected the left side. But she's an intelligent woman and the left side. Then I asked her for Simmons. Simmons for 3 times, 1, 2, 3, 1, 2, 3, 3 days. Today, from yesterday, she's getting relief. And today, she morning is done 3 times. Today she has got relief, full.
I want to add here something. When
Yes.
we over telephonically advise a positional test, try to take the video as well, because many a time vestibular migraine present with positional vertigo. So that has to be what do you say, Surojit? So it is
That's
very much
correct.
essential.
That's
Yeah.
correct. But myself, I know I had done Simmons and I could correct. Except last time, Surajit has corrected me my positional vertigo. Actually, Simmons is a telephonic maneuver. It is written in a book. And established maneuver. I even Oil India, Julia done 3 cases I have corrected with Simmons
No,
maneuver.
it is right, Dada. Sir, it is right. Simmons is the
No,
treatment
if
of
the
choice.
facility is there, you can go for video, all the stigmas. Because if there no facility, then how can you get this all the
No,
pictures?
what I wanted to say that all positional nystagmus in this whole bike may not be a BPPV. But I have my
That's
own
correct.
relative. 3 days back, she is from Guwahati. She is complaining of giddiness. Then I checked. So I did supine. She cannot move the head towards the left side. Initially, I thought it is a horizontal canal BPPV. Then I checked. She was lying down on the right side. That side there was no nystagmus. When she is in the supine position, then I saw the nystagmus on the left side. There was no nystagmus, so it was position induced nystagmus. So it cannot be a horizontal canal nystagmus. So that is important. Actually, many a times we have to, if it is possible, take a video, and then it
It
will
will
be
be possible,
helpful.
yes. No, it is always better to go for video, but some people cannot do the video of the nystagmus. Myself, this vertigo comes to me positional, I cannot, the Surajit has seen me, the way I cannot take the video because so much vertigo, you cannot, in a chamber once a lady so much shouted in this bike, then all people came to me, would I have done something? Like the attendant there. Therefore, some people may be vigorous, severe type, it may be mild type, it may be moderate type. You cannot tell. Thank you for experience. I'm
Roji,
telling the
Anjana,
experience also.
Anjana, 8:38.
Yeah. We'll just finish off. Dr.
Finish.
Kripamay wanted to say something.
Yeah.
Kripamay.
Just a query. After doing this Eplis maneuver, is there any specific precaution you want to advise to the patient for further recurrence or anything like that?
The present dictum is no. There is a list that we used to prescribe a lot, but nowadays it said that nothing is necessary.
Like lying down straight.
Yes, all those lying straight with 45 degrees up, not moving, this, that.
Those things are not required nowadays.
Nowadays it is said that those things are not necessary.
Okay, fine.
In lateral canal?
Actually, there is a home therapy in the sense that with the slightest perception of vertigo, the patient should do the home therapy. Sitting first, then going to the one side, lying down for 30 seconds, and then coming back to sitting, and again going to the opposite side, and coming back to the normal central position. So this is a home therapy which should be done 5 times every time.
The blender of exercises, sir. Yes, sir.
Yeah, no. These are not the actual head and neck exercises. These are not actual vestibular rehabilitation therapy. These are meant for the purpose of BPPV only, home therapy, and 5 times, every time 5 times, and about 3 to 4 times a day should be started, and it really gives very good result. With the slightest perception of vertigo, patient can do it.
Thank you. So anybody? Yes.
I want to tell one thing. Generally,
yes, sir, sir, you are missing. Sir, we are only seeing the ceiling fan. Sir, we are only seeing the ceiling fan.
You can see.
Now I can
what
see you,
we
sir.
do is generally, first history is always important. I always do desulfide, and once I find out which canal is involved, then I have got chart. I generally already I have got chart, so I give it to the patient. Initially, I show them once I doing the FPs, and then subsequently they can do at their residence also. I ensure that they do it regularly, and then ultimately we
Should
get the
never,
good result.
sir. Please should never be done without doctor presence. Simmons they can do at home. Branderoff they can do at home. Barbecue they can do at home. Please should never be done.
Please difficult for the patient.
Because even a slight difference in the angle can result in canal conversion.
Correct.
Yeah,
please
I know.
should be to be tested first.
I generally give them, the videos and all. I have already print out. I have got with me. So how long he has to wait? 30 seconds each time. That they follow according.
Mukherjee has so much patient, he doesn't get time. Therefore, he give the chart. No, Mukherjee.
Hey, Mukherjee sir, sir, motor pathai dile hol sir, moi kori.
Oh, pathai dile tumhara. Tothapiu no pathai.
Anjana wanted to say something. Please, Anjana.
Yeah, Surajit. Yeah, I joined in the last minute. So, which canal to be tested first? It's a horizontal or posterior?
That was a discussion going on just before you joined, Anjana. So the consensus is, if you go by the technicality of it, since posterior canal is the most common, we should test the posterior canal first. But if you go by the patient's satisfaction, because the patient is very apprehensive, if you go and do the Dix-Holpike at the very first, most of the patient jumps up. So we find, me, Anjana Vaido, most of us, we find that if we do the supine roll first, without touching, we ask the patient to lie down and turn the head right and left. That not only takes care of the supine roll, but it also gives a sense of the fear goes away from the patient. Then we can do the Dix-Holpike very nicely. So yes, as Akhil Sharma sir had also mentioned, that if we do the Dix-Holpike, we can actually tell all three canals. But unfortunately, if we, in many a patient, they are so apprehensive that we try to make them do that, they will jump around. So as I said, the technicality, if you go by technicality of it, Dix-Holpike is the only thing we need to do. But for the practical aspect of it, we always do the supine roll test first, and then we go for the Dix-Holpike.
Okay.
Anjana,
Anjana,
I want to ask one question. Anjana, in the supine roll test, by the only the turning of the head or the whole body should be turned. That's some always if this point is discussed.
Actually, we do the turning of the head only.
Because the turning, but there's a discussion in one webinar on there should not be only turning of the head. If the proprioceptive something, the stress receptor, something like that, they may give a false vertigo type something. But the stigmas you will see that's automatically will isolate.
Sir, what we need to do is to turn the semicircular canal.
Yes, that is the most important.
We need to turn the semicircular canal. So if the patient doesn't have any problem in the head, so there is no spondylitic problem or anything, then we can do a 30-degree turn of the head without giving too much stress to the proprioceptive. The 30-degree angle turn will not cause much. If you go for 45-degree full turn, then. However, if the patient has spondylitis, if the patient has any other neck problem, then we can make the patient turn the whole body. The idea is not to turn the head or the body. The idea is to turn the semicircular canal.
Correct.
So one question, another question to Surajit. So if in Epley's maneuver in the third position when the patient sits up, if there is giddiness in the third position, what should be the impression and what to do next?
So if there is still giddiness once the patient is coming up, now what I say take is there was giddiness in the previous positions also. There was giddiness in the first, second position also. So in this situation, in this situation, the likelihood of a uncompletely done Epley's is there. If there is giddiness while moving up. So it is always better to repeat the Dix-Holpike. Now there are again confusion here because some say to repeat it immediately, some say to repeat it after 3 days. But whatever is, I repeat it immediately. So it's repeat the Dix-Holpike, and if there is dizziness, go for a second appli on the same sitting. That is what I do. Some say you should not do that. You should wait for 3 days and do it. That's the thing. Suppose there was no giddiness on the first and the second, and the only giddiness is there when the patient is coming up. Now that's a completely different thing now.
That is different. But
That
there
is
is
different.
first and second position, but there was giddiness in the third position also. Then
While
we
coming
should
up.
consider that it is a uncompletely done.
Yes.
Correct.
Yes. This
And
is
second,
where that whole
that it
pearl
can
string of
enter
things comes.
the candle at the same time. Would you like to taste the anterior canal in the same sitting? Because sometimes we've seen that if it is done is incompletely, it might
move towards the anterior canal. I am not very worried about the anterior canal. Yes, I would like to test, but then I'm not very worried about the anterior canal, because anterior canal is anatomically so nicely present that if the patient walks around also, in maybe 24 to 48 hours, it's likely to come out.
It will correct it automatically.
I'm more worried about the horizontal canal.
Yes.
So if big Solpike has nothing, then I would like to do a supine roll and see if the horizontal canal, there is any conversion to the horizontal canal.
You do that in the same sitting.
Yes.
Okay.
If the patient is complaining, if the patient is not complaining, even if I do, see, in all my patients, after Eplees, even if the Eplee was perfectly done and there's nothing, I do ask the patient to come back on the day 3 and repeat the Dixolpike. If there's nothing in the Dixolpike, then the whole process, I again do a supine roll and everything. The patient, any BPPV patient, even if I think I have done a perfect Eplees and the patient is perfectly fine, I will ask them for a review on day 3.
Anjana, I think time.
Yes, I'm waiting for that.
Anjan, you have to announce your Northeast update. Anything workshop? Biswa and Anjan?
This is not mine, sir. It's done by all only. So on 30th of October, so there will be a workshop kind of program that will be telecasted live in the internet, and I invite you all for that program. So it will be a live surgery plus interactive session. So it will be telecasted from Pratiksha Hospital, and all are So you all are invited for that. So it will be on 30th October after 3 p.m. So it will be continued till 10.
Hello.
Hello.
30th October.
30th October.
Friday, sir.
Endoscopic tympanoplasty, cochlear implant, mastoid, and all these cases.
So it will be under the banner of Northeast that, and it will be
done by actually Pratiksha Hospital, because
Anjana?
Surojit,
yes.
Can you conclude?
Yes.
Is it over?
Yes, I'd like to thank all the present seniors and teachers and friends here, but the biggest thanks has to go to Dr. Bibuhti. A very wonderful presentation, a very elaborate yet concise presentation. It was a very well done. A big thumbs up to you, Dr. Bibuhti. You have done great, not only justice, you have done wonders to the presentation. Thank you. Thank you to NEBAOI and specifically to Fazia Baido and Anjana Baido for giving me this opportunity to host this, moderate this session. Thanks to all my seniors, and now hand over back to the academy, NEBAOI academic group.
Anjana, please.
Okay, first of all, I would like to thank Dr. Bibuhti for your very wonderful presentation, and Dr. Surojit, as usual, thank you for wonderfully moderating the session, and then all the participants for their active participation in this classroom. So what I want to share something here. So next webinar, can you see the slides?
Yes,
Yeah.
yes.
Next webinar, the speaker is Dr. Manish Singh, and the topic will be failure of endoscopic sinus surgery and revision surgery. So moderator will be Dr. Dr Bibuhti. So it will be on the 30th of October. So that's what yes.
No, is it 30 or 29, by the way?
22. Yeah, sorry.
Next Thursday is 29.
Okay, sorry. It is 29. 29.
So
38 is Nintu. 38 is Anjanda's show.
Okay, so sorry. 29th 29th of October. So please do join. That's what. So we can conclude today's classroom.
Thank you. Thank you very much.
Thank you.
Thank you very much, everyone. Good night.
Good night.
Good night.